once again. Today is the another webinar series, and today we actually have a really special tribute about a topic that is really dear to us, and it's a topic called sudden death, and we wanted to talk about the heart and more. If you notice today, we're going to actually dedicate this to Steve, and I just want to tell you guys a little bit about Steve. Can we have the third slide, please? Okay. On the 5th of September, 2022, we started this webinars for the very first time. A few hours to when the webinars were supposed to start, we had a technical problem because our technical person that runs the Zoom for us was nowhere to be found. So one of my team members, Dr. Osagie, actually said, listen, we've got someone that can help us run this webinar, and his name is Steve Spotlight Osagie. Immediately, she got onto the phone with Steve. Steve actually proffered a solution to what we needed to have done. And Steve said to me, listen, Chichi, we'll speak after this, so this never happens again. That was on the 5th of September. Rewind a month later, at about a few minutes past midnight, I was speaking to Siska, again, Dr. Siska, about getting Steve on board to actually run the program for us. And remember that before we decided to start this webinars, we had actually planned the topics we're going to talk about. And throughout this past 1 month, Steve had kept in touch, was trying to see how we can actually get help to most people, which is the reason why we do these webinars in the first place. We had a conversation about speaking to Steve the next morning about actually getting all this going. And I can remember being in a meeting, an MDT that morning, talking about patients in my regular NHS job when Dr. Siska sent me a text message. And the text message said, I'm sorry, I cannot run the webinar tonight because Steve has just, my brother-in-law just died. That was what she sent to me. Immediately, I did not think about Steve, to be honest. I thought maybe it's another brother-in-law, right? Because I had just spoken about Steve a few hours later, before that time. So I got on the phone to Dr. Siska, and then she told me that that Steve had been found dead in his sleep, and he was actually watching TV, and he had been seen by his mom just a few hours before that time, and we're shocked because Steve was very active. We didn't think about. Steve had never been to a doctor for any reason at all. And Steve was classed as like really healthy. And we were shocked about why Steve had already just experienced sudden adult deaths. So today is very important to us because we decided to dedicate this to Steve, because even though we had chosen this topic ahead of time, we did not know that today, instead of working with Steve to make this webinars work out well, that we'll be talking about a topic that we had discussed with him in the past and somehow had actually happened to him. So I just wanted us to take like 30 seconds, just think about Steve, because with Steve left his children, his aged parents, who he was actually looking after when this happened. And more importantly, Steve also left the team because he was part of our team. And it's sad for us, but so it's a topic that we think that if we could get across to a lot of people, perhaps, I don't know, perhaps there was something we could have done because of Steve. So this is actually dedicated to Steve Spotlight, who is actually part of our team. And joining us today to speak about this topic is someone that's, how do I talk about her? The first time I was introduced to her, I went, as I always do, to go and research about her because I work really closely with the One Welbeck. And there was something about a quote that she talked about. She says that her aim is to deliver first-class patient care. And that's very powerful because a lot of people never think about healthcare as being first class. You know, a lot of times we all aspire to get into like first class plane. We want to stay in 5-star hotels, but we never think about our health in the same tone. She trained at the prestigious University College Hospital in London with distinction. And she also had honors in anatomy, and also later went on to actually have a PhD. So I'll say like she's like a double doctor medicine, then doctor PhD. She actually continues to train other people in cardiology. By the way, she's going to tell us a little bit about cardiology. But what's really important is that one of her expertise is about cardiac rhythms and also how to manage and investigate these patients. Not only is she a cardiologist, she's also quite trained in electrophysiology, and then she also looks at things like syncope, which means when people have blackouts or they collapse. She also looks at things about heart muscle itself and tries to understand how the heart muscle works and looks at things like cardiac failure. She also speaks to families who have suffered from cardiac, where they've got members suffered from cardiac death. And she's also qualified in the horrific and obviously devastating disease that ravaged the country for the past, well, not just the country, the world, for the past almost 3 years, called COVID-19, and more importantly, long COVID, which a lot of people are suffering. Millions of people around the world continue to suffer from this. What is impressive about this doctor is not just that she's not just a normal doctor, she's also a female cardiologist and one of the very few that you know in the country. And more importantly, she's also doubly qualified, as I said earlier, in electrophysiology, and she's a woman doing this thing, which is very impressive. For me as an orthopedic surgeon, when I see other female doctors, I'm like, wow, if they can do it, I can do it. She's published in a lot of journals. She speaks in a lot of conferences. So we're really lucky to have this world-renowned cardiologist come and speak to us tonight. She's worked in a lot of centers of excellence, including the Royal Brompton, the Harefield and the Chelsea and Westminster NHS Foundation Trust. And if you're not very conversant with London, because we've got people logged in from different parts of the world, it's worth remembering that this is just the heart of cardiology in the UK, the hospitals where she's worked in. She currently is the clinical director for the North Middlesex University Hospital. And when we talk about Dr. Aisha Opal, she also doesn't just do medicine and cardiology. She also lends a voice to councils and tries to actually make a difference. So she's a member of the British Heart Rhythm Society. She also sits as a UK ambassador to the European Heart Rhythm Society for Young Electrophysiologists Committee. She actually continues to train the next generation of cardiologists and has received excellent feedback as a trainer, particularly for a woman. And more importantly, Aisha, like Steve, like a lot of us here, is also a mom. And I read a story where she talked about that she's also a daytime mom, and I saw that and it was quite impressive for me. So I'd like to welcome Dr. Aisha Opel to this meeting as we talk about sudden cardiac death in memory of Steve. Thanks, Dr. Aisha. Thanks for coming.
There we are.
Thank you.
You should be able to hear me now. Well, thank you very much for the introduction. But firstly, I've got to say I'm so sorry for your loss, for the entire team and loved ones, extended family. It's funny, as you say, you have these topics, or funny is not the right word, but you have these topics all set out in place with Steve there to help you. It's just, life has this funny way of hitting you in the face like this. So I'm so sorry for your loss, and thank you for the introduction. I'm not sure that was all me, so thank you very much indeed. So look, I only hope I could do Steve a fitting tribute this evening by talking about this topic. I really hope I can. I was sent a list of questions and queries that people might have that I'm very happy to talk through and more, and keep this interactive if you want or not, if you want me to speak, whichever way is helpful.
I think what we're going to try and do is go through a few of the questions, and then we'll let the audience also ask questions. Because I think what's really important to people, like why we started this, was to get people just asking us questions directly of what they're worried about, right? As you said, we did not plan for this to be about, about Steve, right? But it was because we just felt like this has happened. We wanted people to come in and ask questions and maybe find some form of closure, right? Or find some answer that could help, like, protect the next person. Who knows? There might be something else that we could have done that we didn't do. And then let's see how it goes. So I think, like, today, as we said, our condolences go to the Osagie family and Steve's children, his wife, his brother, his sister, his brothers and his sisters-in-law, and more especially his aged parents. I had the privilege of speaking to his mom last week, and her question was like, what happened, right? And I think that's why this topic is so dear to our heart, and we really wanted to let people share in it. Since we shared it, a lot of people have just talked about how they've experienced this one form or the other, and they really are grateful that you're here. I cannot even thank you enough for being here and joining us, right? So we're really grateful to have you.
Not at all, it's my pleasure.
So I think the first question I'm going to start out with is to say, who is really a cardiologist, right? A lot of people don't really understand who a cardiologist is, and maybe that's where to start to break the ice. So there's a bit of like, we want to enjoy this at the same time and get educated.
Sure, absolutely. So look, a cardiologist, just really simply, is a heart doctor. So we deal with everything to do with the heart. So as a cardiologist, I should say, we're not surgeons as such. So we really shouldn't be opening up the chest. If the chest is being open for one of our patients, then something's gone, a little bit wrong in terms of an emergency. But we are physicians. Now, I think what's really important to appreciate as a patient, that if you feel that there's something wrong with the heart, the first thing I should say is that a lot of people say, oh, I don't want to trouble anyone. Go and see someone. It doesn't matter. If there is a change, just see someone. But as cardiologists, we actually specialize in different areas. So we are all trained in all aspects of cardiology, and we can all deal with all aspects of cardiology, but we have our specialists' interests or area of training. So for me, that's heart rhythm and everything that comes with that. And actually with heart rhythm, there's a lot of interplay across the other cardiology specialties. So I deal with the electrics of the heart, and many people will say or like that to an electrician, if you like.
Nice, I like that.
There are cardiologists who deal with the coronary artery, so that's to do with chest pain, angina, heart attacks. They're known as plumbers, because I suppose the arteries are like tubes and pipes. There are also cardiologists who deal with heart failure, so that's the pumping mechanism of the heart, and those that deal with heart muscle and heart muscle conditions as well. Now, as an electrophysiologist or a heart rhythm doctor, I mentioned that there's a lot of overlap with those other areas of cardiology, because, there are patients who have heart attacks who get heart rhythm problems. So the rhythm problem may not be their primary reason for coming to see a cardiologist, but people who have heart attacks are susceptible to getting abnormal heart rhythms, as are those patients with heart failure, as are those patients who have primary heart muscle conditions. And then there are electrical problems per se, which you can develop in your life and which you can be born with, and electrical problems as well that, you may not find any evidence for until sadly a family member dies or is picked up by chance. And some heart muscle conditions are like that as well. So, cardiologists very simply are heart doctors, and we deal with each component of the heart. Some of us are invasive cardiologists, meaning that we do procedures. Those are usually from the top of the leg or from up here, depending on our specialty. So electrical doctors like me and the plumbers who deal with coronary arteries, we all do procedures as such. And there are some of us who are interested in imaging of the heart, and those are doctors who also deal with heart failure patients as well. So there's lots of overlap in what we do. I was also asked about how the heart works, and it's probably a good idea to go on to that, because then I could describe the different components. Okay. And I've got, so the heart here, very simply, this is what I say to my patients. The heart is a muscle, and more specifically, it is a muscle bag. That's it. It pumps, it contracts like this, just like every other muscle in your body. And it consists of 4 chambers. I don't know if you can see me move the cursor around, can you? I don't know.
No, we can't see it, no. Yeah, we can see it now. Yes, we can. Okay. The cursor is moving, yeah.
Okay, fine. Yes. So the muscle is divided up into 4 chambers, very, very simply. And here in blue, this side of the heart, the right heart, collects blood from the rest of your body. That doesn't contain very much oxygen. That's why it's in blue, because blood carries oxygen around the body. It's the fuel for the body. So that's what the heart's doing. It's pumping it around. So it's got to collect the blood that's very low in oxygen from the rest of the body. It then pumps it out to the lungs. The lungs then send oxygenated blood back to the heart and then to the rest of the body. In fact, if you go to the next slide, I've got a little, please.
Ahmed, can we have the next slide, please? Perfect.
Oh, I meant to say, actually, it's in the next slide, but the heart is a muscle bag, but it has these little valves inside. The valves I describe to patients as doors, floppy doors. and they open and close, and they allow the blood to flow the right way in the heart. Because if otherwise your heart is just a sac with no divisions within it, all the blood will collect and won't know where to go. So they're like little doors that open and close as the heart pumps. If you go to the next slide, please. That is lovely. So here, yes, here, this is showing you the blood being collected from the rest of the body, and then it's going out through this vessel here to the lungs. And then if you go to the next slide, please. And then it comes back from the lungs into the left side of the heart here, and then out through this vessel, which is called the aorta, to the rest of the body. And the next slide, please. So the heart, as I described, is a muscle. So as you can already imagine, there are things that can go wrong with the heart muscle that we can deal with. Outside of the heart, so you can see the little sort of shadowing of the heart in the background. So on the surface of the heart, there are what we call coronary arteries. So it's when these get narrowed or blocked that people get chest pain, so angina, and can have heart attacks, okay? So as we've said, the heart's a muscle, so things can go wrong with that. It's got a blood supply, so that's its own fuel. Things can go wrong with that, so you need cardiologists to deal with that. And then if you go to the next slide, please. And it has an electrical supply. So the heart has its own electricity. So those heart cells, they generate their own electricity in order for the heart to pump. The heart cannot pump without the electricity of the heart. So the electricity starts up here, it goes towards the center of the heart, down these chambers, and then you get a heartbeat. Essentially, that's what you're feeling. So things can go wrong with the electrics of the heart as well. Hence, you get cardiologists who deal with different areas. Do I have another slide after this?
Yes,
I think
you have one more slide, and then we're going to stop sharing the slides. Yes.
Yeah, absolutely. So I just put this up because we're talking about, I'm just going to put this in here. We're talking about death. We're talking about sudden cardiac death, whatever cause. And this is such a huge topic, actually. But one thing I really want to say to you as doctors, patients, laymen, is this something that you feel that you might want to do to ever help someone who suffers collapse due to cardiac arrest, please learn CPR. CPR is cardiopulmonary resuscitation, and you really, 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 really can save a life. Because if someone collapses in the street and they're having a cardiac arrest while the emergency services are coming to that patient, they are dead. Essentially, you can act as their heart, and that is by doing cardiopulmonary resuscitation. You are helping the blood get around the body. So I think it is really important to learn, and it's not very complicated, and I think children should be learning it too. So
completely agree with you. I think that's
my nutshell about that.
I think learning CPR cannot, like, has to happen for most people.
Yeah,
I'm just wondering why we don't really, like, I know we do a few like CPR training, especially for health workers, but I'm just thinking that maybe it's time to start teaching more people CPR at home. I don't know what you think about that. Like,
yeah, I mean, there are various things that, there are, in the UK, there's St. John's Ambulance, there are CPR courses you can go on. My other view is that it should be taught in schools. And there is this initiative coming into play. I don't know when it was being spoken about, like many things are for secondary school children, but I actually think that primary school children can learn it too. So, and as I say, it's not that taxing and it's not so difficult to learn.
Yeah. Thank you so much for teaching us how the heart works, and obviously stressing that CPR is so important. It's really, really like a big thing to take out from this meeting. And I think for everyone else listening and people that cannot listen, I know the people in America have said, oh, we're really sorry we can't join because it's Thanksgiving, but they can catch up later and hear what we have to talk about, and hopefully be part of this conversation, even if they're not here right now. So like for everyone else, remember that in the next 10 minutes, you should be able to send a question directly to either myself or Ahmed for our renowned cardiologist. This is your opportunity to ask questions. But in the meantime, I think that we want to talk about, what does sudden adult death really entail? Because I think for the family, I keep saying it, like I hear Steve's mother's voice on my ears where she said to me, what could have been done? What happened to my son? I don't know what's happened to my son. And I think for me, it was a moment where I was like, I'm a surgeon, but I don't really know what to say to her. you know?
Yeah. Well, it's very difficult. And, and sometimes for cardiologists as well, we can postulate, oh, it could be this or that. Now, there's different considerations actually. So sudden cardiac death, it just means, the heart unfortunately stops for whatever reason. And if it stops, it's not going to pump blood around the body, of course. And that results in a person becoming unconscious and not being able to breathe. Now, when you start thinking about causes of that, actually, the most common cause is coronary artery disease. So you remember how I showed you the arteries on the outside of the heart? So the most common cause is one of those arteries becoming blocked. That's called a heart attack. And that can happen suddenly without people suffering with any pain at all. They may have risk factors for cardiovascular disease. And when that artery blocks, what actually happens is, because that part of the muscle is being starved of blood, the person in question then develops an abnormal heart rhythm that is not compatible for life and causes them to collapse and lose consciousness in that way. So that is by far and away the most common cause of sudden cardiac death. Now, for Steve's case, that may or may not have happened. There are, of course, other causes. So coronary artery disease and heart attacks makes up about 80% of sudden cardiac death. And then you may have heard this term SADS,
yes, yeah,
which is sudden arrhythmic death. Now,
yes.
That other 20% consists of electrical problems of the heart that are inherited, that are really, really difficult to pick up just per se. Usually when those electrical problems are picked up, sadly, it's because there has been a family member who has died. And as a result, the first degree relatives have been screened. There are also heart muscle conditions which can result in sudden cardiac death as well. And the mechanism of all of this is that the heart stops due to an abnormal rhythm which is not compatible with life, essentially. Now, we can talk about, lots of areas of this, but if we think about the rarer causes, so in particular, if someone very sadly young passes away very suddenly, they might go on to have a post-mortem. Usually that would be recommended, to be honest. Now, at post-mortem, if there has been coronary artery disease where there is a blocked artery, that can be seen. If there is a heart muscle condition, that can be seen. You're not going to see abnormal electrical activity, of course, but a heart muscle condition might be seen, or a blocked artery, and then the coroner will say that's the cause of death. Sometimes nothing is found at all. So if there is a primary electrical condition which is inherited, there is nothing to see on post-mortem. In these situations, though, where there's been a family member who's died suddenly in this way, and particularly when they're young, family screening is then recommended. And that screening involves usually just an ECG,
okay,
and a scan of the heart. So that's generally on the chest, an ultrasound scan. And that's just that the ECG is for us to see if there's any electrical problems that we can pick up, so the inherited ones. The scan of the heart is to look at the heart muscle and whether there's, any condition which has not shown itself in first degree relatives. So, siblings, parents, children, that needs to be followed up and looked after. Now, if we are thinking of, again, that rarer group, that 20%, and how, to answer, Steve's mother's question, why and what could we have done? I remember you saying that Steve was young, fit and healthy, had no reason to see a doctor. So then obviously you were in a very difficult situation. I'm not sure, actually, that unless he was describing any symptoms, anyone could have done anything, sadly, in all honesty. If he was describing chest pain or dizziness or palpitation, but then he would seek medical advice. But usually for that minority of patients who suffer this, unfortunately, a collapse with loss of consciousness, sudden cardiac death, if people are not resuscitated, that's the first presentation. Some people will be resuscitated. You know, you very typically hear of footballers who fall on the pitch and they just happen to be in the public eye and they might be successfully resuscitated. Actually, you know, the mortality rate is high of sudden cardiac death in the community. But that's usually the first presentation. So, you know, very sadly, you know, for Steve, I think if he was well, there's not anything that anyone could have done to predict. But, you know, going forward, parents, brothers, sisters, family members, children would need to be screened.
I was going to ask you a question. Before, obviously, this happened, when we had chosen this topic, we had read a story about a gentleman called Andrew Barry that was in the papers. Again, 35 years old. The wife had described that he had had dinner and they were talking, and then he stood still. And she said he went like ashen and then he fell forward, right? And then by the time she thought he had a collapse before, so she thought it was repeating itself. So what I was going to say to you is, like, obviously we've talked about chest pain, we talked about palpitations. Are there any other salient points that people, or pointers more than that people should look at? Because she then said, and he fell to his death. And for her, it was quite shocking because he was 1 minute speaking to her, the next minute he was gone. And as you talked about, sometimes the postmortem has no answers. And for her, she couldn't find an answer of why her 35-year-old husband had just died just like that, you know? So I'm just wondering, is there any other thing people should be looking out for?
Yeah, so look, I mean,
not so obvious, like palpitations and chest pain.
Yeah, sure. I mean, you're absolutely right. And you know, the reason that I wanted to go over those images was really just to allow people to understand. So coronary artery disease, chest pain, heart attacks, people know about. You think about the heart and that's what people think about. Oh, I've got chest pain, I must see a doctor. Or, you know, palpitation, something's not quite right. But I think also if there is, you know, breathlessness, dizziness, if there has been a collapse, you should, if there's a change, you should just seek medical advice. You're not wasting anyone's time. That's why we are here, to be honest. Now, look, all of these symptoms, be it chest pain, palpitation, breathlessness, dizziness, passing out, there are so many things that can cause them, and things which are not necessarily sinister. But I think that if there are any of those symptoms, even if they are mild or minor, it's a good idea to seek medical advice, because then, you know, if a patient comes to me, I will make sure that I've spoken to them, included the family history, and then undertake an appropriate and relevant course of action, investigations, with many of the relevant things in mind for that patient, and look at in detail to make sure that we are not missing anything. Now, sometimes, you know, inherited electrical problems don't always show up on a single ECG. They're not always fixed, they come and go. So those sorts of things need to be borne in mind as well. Sometimes people ask about genetic testing for these rarer conditions. Now, to be honest, I would not recommend that people just go out and get blanket genetic tests done.
You mean the cardiac markers, right? Is that what you mean? The cardiac markers, genetics, yeah. Yeah,
I mean, specifically looking at there are lots of genetic tests available. The reason I say that just blanket genetic testing should not occur is because there are lots of abnormalities that might be picked up that we don't know the relevance of. So it's really important to take whatever information that we are gathering in light of that individual and their family history. If someone has had a family member who's passed away very suddenly, particularly at a young age, you know, they come and see us and we go through all the family tree, so on and so forth, and do the appropriate testing in that way. And that's really important. And sometimes we find something and sometimes we don't. You know, it's a difficult area, particularly whereby there's been a post-mortem or not, and there's nothing that's been found. But the best thing to do is if you're worried about any symptoms, if there is a family history of sudden cardiac death, dying suddenly at a young age, a family history of cardiac disease, just see a cardiologist.
See a cardiologist. Yeah.
Just see and even if that conversation is, it's okay, or we do the relevant tests and it's okay, actually that's the best thing to do.
Mhm. I was going to say to you, like, obviously we're a concierge company and we're quite big on health assessments every year, right? Getting like a full MOT, checking from top to bottom. And my question will be, how many cases of like things like this can be prevented by regular MOTs?
Yes, so I don't want to call it it's not a double-edged sword, that's not what I mean. Okay, so we've got to think about what we're looking for, and I'll explain what I mean. Now, if we are looking for, as I've mentioned, let's just say we are screening for electrical conditions which might be inherited and that we can see on an ECG, or we're looking for heart muscle conditions, that's okay. You know, we see it or we don't, and we can move on from that then. Now, coronary artery disease. So if we're looking for narrowings or blockages in the arteries, that's where we have to be a little bit careful. And I'll explain that. So coronary artery disease is, you know, those arteries, the tubes I showed you on the outside of the heart, when those get narrowed or blocked, that's when people get angina and heart attacks. Now, not everyone with angina dies. Not everyone who has a heart attack dies. If we are going to look at the coronary arteries or understand the blood supply to the heart, that has to be within context, meaning if we do a test and we see a narrowing, we've got to think about what to do about that. That's only really important if a patient has chest pain, okay? We all start to get furring up, irregularities, a bit of narrowing of the arteries as we get older, actually. So if we see a little bit of narrowing, are we going to start opening it up? The answer is actually no, because if we do that without any symptoms, we are going to cause more harm than good, if that makes sense. However, if someone has chest pain, that's a whole different ball game. If we open that narrowing up in the context of chest pain by using stents, that relieves pain. It doesn't make people live longer. Now, I did mention that coronary artery disease is the biggest cause of sudden cardiac death. I mean, look, that tends to be in an older population. I've had some quite young people with coronary artery disease as well, which is kind of scary, particularly when they might be same age as me or a bit younger, because, you know, you always associated angina, heart attacks with older people. And it is a condition of older people rather than, you know, sudden cardiac death when you are younger, where it's more electrical or heart muscle. The most important thing to manage coronary artery disease is prevention. Prevention, prevention, prevention. Now, what do I mean by that? That means two things: managing risk factors. Now, risk factors for coronary artery disease, yes, are family history, your gender, your ethnicity. So, unfortunately, you know, Asian men with a family history have quite a risk. You can't do anything about those, you know. I know we can change gender nowadays, but that's not the same thing, obviously. That's not the same thing. I always have to caveat to my patient. Just to say, by the way,
your bed gender is your bed gender for the
genetically, whatever your gender, yes. You can't change those risk factors. But what you can do to prevent coronary artery disease is make sure you don't smoke. Smoking is evil. And I say to patients, I promise you.
I like that word, evil.
It's evil. I promise you, you're going to have a problem with your coronary arteries if you smoke. Obviously, there is vaping nowadays. Actually, we don't know the long-term effects of vaping. And I say to patients, okay, fine, it's probably better than smoking, but please try and stop, you know, come off it, because we just don't know. We don't have the data to know what happens in the long term. Manage your cholesterol. And I know we've got people maybe from different countries here, so the numbers and the units used are different worldwide. But cholesterol needs to be managed, blood pressure, blood sugar, weight, make sure that you are exercising and following a good diet as well. So all of these things are risk factors for heart disease. And I mean coronary artery disease. I don't mean the electrical problems or the heart muscle problems that we've talked about. I mean coronary artery disease. So all of those things need to be managed to decrease your risk. So, I mean, of course, you can still have heart disease because there are genetics involved, but it just minimizes your risk. So really, really important.
Thank you so much for that. Like, so we talked about risk reduction, making health like your priority, really. There's a question, someone's written that they've had a relative, the sudden death, and the autopsy had said the patient had cardiomyopathy, right? And the question is there an increased risk in cardiomyopathy in Black men of African descent? That's the question. I think that's what they've experienced, yeah.
Yeah, it's a really, really good question. So cardiomyopathy is one of those heart muscle conditions that I mentioned. So cardio means heart, myo means muscle, and pathy just means there's something wrong. Disease. So that's what it means. So just to cut the jargon, that's what it means. Now, there are lots and lots and lots of different types of cardiomyopathy, some which make your heart just bigger and we don't know why that occurs. Some causes are inherited, whereby the heart muscle can become very, very thick. And in others, you know, sometimes fat, and I don't mean just because you're overweight. I mean, there is a condition where fat infiltrates the heart. And then there are acquired causes of cardiomyopathy. So, for example, there are particular proteins that can infiltrate the heart that can cause it, and therefore you treat that condition to treat the cardiomyopathy. Okay. Now, an increased incidence in Black men in particular. Now, it is observed. Now, none of these heart muscle conditions, if you like, may necessarily be more prevalent in Black men. But, you know, I do observe in my practice that the heart can be a bit more muscular. There is a lot of high blood pressure. High blood pressure can cause the heart muscle to become thick. That's not the same as cardiomyopathy as such. My advice would be the same as what I alluded to before, and that is, if you've had a family member, first-degree relative who's passed away, get screened. But that's the same for anyone, whether you are, you know, Black, Caucasian, Asian. So, you know, those heart muscle conditions that I mentioned aren't necessarily more common in Black men. But if there has been a first-degree relative, you're concerned, just speak to a cardiologist and get screened.
Okay, thank you. So I was going to ask a question. You know, we talked a bit about the sudden arrhythmic death syndrome, right? So let's assume like someone's got like an abnormal heart rhythm, like, which is what you really do, right? Is there a way this can be prevented if they've got a cardiac arrhythmia already? And is there a way of, like, I'm sure, is it related? Like, is there like a pathway to making sure they don't have the sudden, like the death from cardiac arrhythmia? Or let's assume they've had like a CPR and they've survived it.
Yeah.
Is there a way to then like treat it? I think that'll be nice.
Yeah, absolutely. We can talk a little bit. Absolutely. We can talk a little bit about that too. So obviously there are different rhythms that can come from the heart. Those from the top of the heart. So, you know, in the picture of the heart I showed, there's actually 2 chambers at the top of the heart and 2 chambers at the bottom of the heart.
Yeah.
Usually, very typically, those rhythms that come from the top of the heart are not dangerous. We worry when abnormal rhythms come from the bottom of the heart. And they can just happen for no apparent reason. They can happen in these inherited conditions where we might see an abnormality on the ECG, which is not an abnormal rhythm, but predisposes someone to an abnormal rhythm. People who have heart failure and whose heart muscles don't work as well as they should are subject to getting abnormal rhythms from the bottom of the heart. also, and those people who have coronary artery disease as well can be at risk of getting these abnormal rhythms, and heart muscle conditions as well. Okay, now, how do we prevent that? So if there is another associated condition like coronary artery disease, you treat that in the first instance. Okay, but you would also make sure that the patient is okay, as well as treating that. So you would put them on medication to try and stop the abnormal rhythm. And there's different ones available, to be honest, and you tailor that to whatever condition the patient has. So you have them on medications to prevent them from getting those abnormal rhythms. There are groups of people where we give them medications, but we also do a bit more. Now, that bit more is implanting a device called a defibrillator. Okay, and there's certain criteria for that. So just for, you know, the non-medics, non-healthcare professionals. So you would have seen on ER,
or Grey's Anatomy, or Dr. House.
Grey's Anatomy,
House.
Whatever medical programs. I was thinking ER came to, I'm thinking, what's ER? Chicago Hope.
Chicago Hope.
UK.
Everyone knows House, right? He has solution to every medical condition.
But deals with the rarest of the rare. And you think,
I know.
You know, but on those sorts of programs, you may have seen people become defibrillated from the outside of their body. So very typically in the olden days, it's not that old. This is what I used to use when I started out. There used to be like these paddles that you put on the chest and then you shock the patient. There's no paddles anymore. They're like pads that you put on.
Yeah.
That's defibrillation. Essentially what you're doing is you are shocking someone out of an abnormal rhythm back into a normal rhythm, potentially saving their life. Now, I don't mean that people are walking around with these paddles on. In fact, funnily enough, you can get vests that do that, but they are rare as hen's teeth. We don't do that to patients. There are defibrillators which we can implant. So we do that through a little procedure. So people literally come into hospital as a day case and they have a wire or two. So they have a little cut here, about that long, and they have a couple of wires put into the heart through a vein. And then they have a little box or a generator about that big, which sits like this. It's a bit about that thick, and that sits underneath the skin. So that's the defibrillator. So it's all inside. And there are ones that don't go into the vein. So they sit kind of around the side here. I'll show you like sort of here. Okay. And the leads are under the skin, but not within the heart. That allows defibrillation as well. Now, the people who get defibrillators are those who have survived a cardiac arrest. So that's what we call secondary prevention, because they've had a cardiac arrest already and they've been successfully resuscitated. Usually, you know, there's a member of the public who started that process and saved their life, actually. So they've already survived a cardiac arrest, or we have seen that they have abnormal heart rhythms, which has not caused them to have a cardiac arrest, but the type of abnormal rhythm that still allows them to survive, but is coming from the bottom of the heart. The other group of patients that get defibrillators are those that have never had a cardiac arrest, where we have never seen an abnormal rhythm, but we know that they are at risk. So those are the heart failure patients whose heart muscles just don't work as well as they should. We know that they are at risk of developing these, what we call ventricular arrhythmia, so abnormal rhythms from the bottom of the heart. So there are things that we can do. So there are medications and defibrillators that we can implant. And then there are other treatments as well for these abnormal rhythms per se. So usually patients have already been on the medicines, have got a device in, but they need a little bit more help and support. So we can do procedures called ablations, where we go into the heart from the top of the leg. We find where these abnormal rhythms are coming from and we burn them out. But for these dangerous rhythms, ablation is not the mainstay of treatment. That only comes into play if the drugs are not helping and the patients are very symptomatic and we're picking up lots and lots of these abnormal rhythms.
By the way, I was going to say congratulations, because I know you started the first day case ablation center for atrial fibrillation in a district general hospital. and it's gone global in the UK. Is that the right word to use? And it's now circulated across the whole country.
Yes.
And congratulations, like that's so impressive, by the way.
Oh, thank you. I mean, it's obviously not just it was.
I know it was teamwork, isn't it?
Always a team.
We always say that it's all about teamwork.
It's always, it's always a team. So I must say, given that you've mentioned it, because a lot of people watching this may well have atrial fibrillation, I must stress atrial fibrillation is not a dangerous rhythm. It is the most common abnormal rhythm. Some people don't even know that they have it. There are groups of people who have palpitation. Some people just feel a bit tired and lethargic with it. It is the most common abnormal rhythm, but the rhythm itself is not life-threatening. It's not dangerous. It can feel horrible, though. There is the associated risk of stroke, which we give people blood thinners for, nothing more. Even if we treat the atrial fibrillation and get people out of it, they still have to manage their risk of stroke with blood thinners. So that's a very different rhythm to the ones that we've been mentioning in the context of sudden cardiac death. Because that's one of the rhythms that come from the top of the heart.
Okay. We've had a lot of questions, so I'm going to try and run through them as fast as I can. So someone said, please, what is isolated ventricular ectopics?
Okay, great question.
I need to be concerned about, right?
No, good question. It was in my head as I was talking the other things. So ventricular ectopic. So ectopic just means extra. So it's an extra heartbeat. Ventricular just tells you where it's coming from. So the ventricles are the bottom chamber. You can't quite see where I'm pointing, but the bottom chambers of the heart, okay? Now, ventricular ectopics are not dangerous. They are completely benign. We all have them. We can have ectopics, extra beats coming from the bottom of the heart or the top of the heart. We all have a few every hour, and they are absolutely benign. Some people start to feel them. People will describe them as being skipped beats. The feeling of missing a beat. Sometimes people will say, oh, I just get this funny feeling in my throat, or it makes me catch my breath. Those are ectopic beats, and they are absolutely not dangerous at all. Some people, I know I said that we all have a few every hour. Some people can have them every other heartbeat. That still does not mean it's dangerous. But what I would do is scan the heart and just make sure that those extra beats, because of the number of them, are not affecting the heart muscle in the way that they are working. And if they are, we give medications to suppress them, but otherwise they don't need treatment. So you don't need to worry about them. The only situation where I would investigate certain things is if someone came along and they had chest pain together with that or something else, then I might do additional investigations. But I would always look at the structure and function of the heart in someone with ectopics, but they are benign.
Okay, cool. And then Anthony Awona from Nigeria says, does age have an effect on cardiac diseases? If yes, what age bracket are more prone to the illness?
Yeah, okay. So with regards to, I suppose, all the causes of sudden cardiac death, if you like, that I mentioned is in the minority group, the heart muscle, the electric, they can occur at any age, to be perfectly honest. Now, the reason why I love electrics of the heart is because I meet patients of all different age groups, because all different age groups can get electrical problems. And I meet lots of patients who have lots of other things wrong with them as well, and lots of other conditions. So primary electrical problems can happen at any age. Now, if we are talking coronary artery disease, so if you remember again, those arteries that sit around the heart, that tends to occur with an older age. I do see younger people with them, with coronary artery disease as well, but for the most part, that is an older age. I mean, I don't think anyone could give you an age range or an age bracket, but I can say this: if your risk factors are not controlled, so for example, if you are a heavy smoker, diabetic, overweight, high blood pressure, cholesterol, you will develop coronary artery disease a lot quicker than someone who has all of those things controlled, if that makes sense. Okay. Now, thinking about rhythm issues, like we talked briefly about atrial fibrillation, that tends to be an abnormal rhythm which occurs with increasing age, but not to say that younger people don't get it as well, but tends to be people of an older age group.
Thank you so much for that. And then from America, there's a question that says, if causes of sudden cardiac death in an individual is attributable to hereditary factors related to electrical activity, is there a measure that could be taken to decrease the chance of a similar occurrence in a relative of the disease that inherits a similar cardiac condition? So they're thinking, if there's an electrical activity that is the cause, what should relatives of the disease do?
Yeah, so again, really great question. And these are really, really, really practical questions, actually. So yes, so if you've got a first degree relative who's had sudden cardiac death, you need to get screened. So you need to have, and it depends what that condition is, but for the most part, screening means ECG and echocardiogram. Echocardiogram, which is an ultrasound scan of the heart. The ECG just shows a snapshot of electrics through the heart, and the echocardiogram, the structure and function. So you can see if there's a heart muscle condition. Now, when you go and see a cardiologist, that cardiologist really should take some time to talk to you and talk about the family history and what exactly happened, because there may be additional tests that then need to be done. So for example, you know, if sadly the first degree relative passed away and it was a heart muscle condition and it's a particular type, then actually genetic testing may come into play for that individual because of what the relative had, and possibly because of symptoms, and sometimes because of what can be seen on an ECG. So screening is the first way to go, ECG, echo, and then there may be additional tests depending on that individual scenario. And we do have to personalize healthcare in that way. And that's why it's so important to talk to patients, you know, because you pick up these little things. Now, if one of those conditions is then diagnosed and you want to manage your individual risk of sudden cardiac death because you've now been diagnosed with that condition, again, it really depends what it is, in all honesty. So for some electrical conditions, once we diagnose it, so bearing in mind it's just a diagnosis, possibly no symptoms, never had a cardiac arrest, sometimes we put people on particular tablets to mitigate their risk. If it's a heart muscle condition, we might just simply monitor that patient over a period of time. Some people do get defibrillators in addition to medication. So it really depends on what the condition is that's diagnosed specific to that patient. But that's the kind of, if you like, help you should seek or pathway you should go down.
Thank you so much. And then there's another question that says, is there a risk of runs of bigeminy or trigeminy for someone that's really young?
Oh, really good. I love these. They're such good questions.
I know.
They're just really practical, you know, just everyday kind of. Okay, so let me answer this. So bigeminy, trigeminy, okay, these are just, you know, medical jargon really needs to be explained to people, because if it is, you get it and don't worry about it. So bigeminy and trigeminy, you don't need to worry about it, okay? This is actually describing the pattern of extra heartbeats, be they coming from the bottom of the heart or the top of the heart, okay? So you know how I said that extra heartbeats, sometimes people have an extra heartbeat every other heartbeat, meaning they have a normal heartbeat, extra heartbeat, normal heartbeat, extra heartbeat, and that's just them, and they're fine with it. That's called bigeminy, bi meaning two, and Gemini is just the pattern. So it's a repeating pattern of normal beat, extra beat. Trigeminy, you can therefore imagine, is having that extra heartbeat every third heartbeat. So you have normal beat, extra heartbeat, normal beat, extra heartbeat on a repeating pattern. And some people just have that all of the time. And some people might just go through periods of having that. Whether it's someone young, a child, or someone older, again, if it's just that with no other condition, is it dangerous? No, in order for me to say that, though, I would have got an ECG done, an ECG monitor done, a scan of someone's heart, just to make sure that everything's okay. And of course, I would have talked to them in detail and just make sure they're okay, and that they're, if anything, getting a bit of palpitation, and that there's nothing else going on, which there isn't for the most part. Very rarely is that needs to be dealt with. But for the most part, ectopics, bigeminy, trigeminy, benign.
Thank you so, so much. Honestly, I don't even know how to thank you. Do you know we've been talking for like an hour?
Gosh,
I'm going to ask you for one more question, please, right?
I think I can just chit chat all the time.
Honestly, it's been so amazing. And I know it's like a solemn session because it's quite big for people, and we're talking about deaths, which is quite a big deal, especially for like most of us. But there's one more question, right? Which is, everyone, obviously the past 3 years has been about COVID-19.
Yeah.
Do we get the vaccine? Do we not get the vaccine? Or the vaccine is going to stop me from having babies? Or the vaccine is going to do this to me? The vaccine is going to do the other thing. So the question is, right, some people have said that there's an association between COVID-19 vaccine and sudden adult deaths. Is there a link? Is there no link? Because these days when you call a doctor and you say, I've got cough, it has to be COVID. Or my chest hurts, it has to be long COVID. Oh, I feel pains. Oh, you've had COVID, it has to be COVID, right? Even sometimes I feel sorry for the pandemic called COVID-19. It's like the new thing, you know, like it's like the new song. We'll probably start like something called, yes, it's COVID, it's not COVID, you know, like I'm like, come on, guys, let's think about something else.
I know, we did feel like that during the, but honestly, it did feel like that during, because everything was being, you know, whether it's sort of blood clots or, you know,
everything's attributed to COVID. And I think
not having children or whatever.
COVID-19 cost me, 19 vaccine cost someone to die for some other reason. I think it's really good to address things like that, because a lot of people are still not vaccinated. A lot of people are still like anti-vaxxers, and they're worried about the vaccine. It is a real disease. And for you that treats long COVID, the devastating effect of COVID-19 is horrible to people.
Yeah, absolutely. You know what, this is what I would say. And of course, everyone's got their own, can make their own choice and, you know, do what they feel is right for them. Is there a link between infertility and the vaccine? I think no. Is there a link between the vaccine and sudden cardiac death? No. COVID, yes, could cause something called myocarditis. I'm going to explain that to you again, jargon. So
I just love how you explain it, because I'm like, I love this, like cardiology 101 better, if that
it does. You see, the thing is, if you explain, it doesn't sound so scary. So look, myocarditis just means myo, muscle, card, heart, so heart muscle, itis, inflammation. Now look, when you get any virus, cough, cold, whatever, flu, you feel pretty rotten under the weather, right? You might have a streaming nose, cough, cold, whatever, as your primary symptoms, but you feel under the weather and horrendous sometimes. And that's because the virus actually affects your whole body. And I'm not just talking about COVID, I'm talking about any. And part of that process is that the virus infiltrates your heart and causes a bit of inflammation. That is myocarditis, okay? And obviously COVID has done that, and we have seen that. And sometimes when we see people, we see a bit of scar. Now, long COVID, and I have a lot of long COVID patients, because they get breathless, and that's not a lung problem, and they get dizziness, and they pass out, and they get palpitation, and some people have all of them with maybe one more predominant symptom, and some people maybe have one of those symptoms. Now, it is, and I am not kidding you, absolutely horrendous that, you know, there are many people walking around who say, actually now with the COVID strains that we get, it's different to the beginning. Actually, the infection, I'm young. In fact, the infection is quite mild. And that is true. There are some of these long COVID patients who have a very mild infection, have a cough, cold, don't feel too bad, or maybe just under the weather for a few days. But the effects of long COVID can be devastating, actually, because I've got patients who cannot walk, literally, or they will get up to walk and their heart rate goes up and they say, this is not right. I'm just going up the stairs and I can't do anything. I can't exercise. I cannot leave the house. I cannot go to work. I cannot think, because of course there's brain fog that comes with this.
Yes.
I cannot concentrate. I can't go to school. I can't go to uni. And I hear all of the same things all of the time. And actually, there's not anything wrong with the heart per se. The mechanism of long COVID is that it involves the part of the nervous system that controls heart rate and blood pressure. That fine control is lost. So you get all of these symptoms. And, you know, we know, I work very closely with one of my colleagues at One Wellbear. We know what to do about it, actually, now. And that is very patient driven. Like, the patients have to be very, very, very motivated to do all of these things. They're very simple things, but they work, and they work over time. And, you know, it's been sometimes months, a year, 2 years before patients have come to us and have been sort of suffering. People do get better, but it takes a long time. So for the sake of not getting long COVID, really, I would just have the boost. You know, you might feel a bit under the weather after having the jab for a couple of days. You know, I really would recommend it. Some of the long COVID clinics that we actually have in the UK, I don't think many patients have found, and I don't mean this by any disrespect, because everyone's on a learning curve, so helpful. There's a lot of data collection that's gone on, but no sort of practical advice or experience or medications are being used that will make patients feel
I think
well.
the problem with long COVID clinics is that they're saying to patients, rest more, do nothing, you're working too much, sleep, take more medication.
Which is not our approach, to be perfectly honest. We
Exactly.
sort of say, listen to your body. You know, there are lots of different things. A lot of it is, you know, fluid, sometimes salt, just various sort of exercises, listening to your body, working things up, breathing. You know, there are a lot, all of the things that we do are about these sort of practical measures, and we take a very, very holistic approach. And with time, if people are not getting better or improving, then we introduce very specific types of medication to help and support people. But we really, really do take a very holistic approach to that individual patient, to be honest, to make them feel better. Yes, you know, we myself and my colleague, we do all the heart tests just to make sure that the heart is indeed okay. And we do a particular test to confirm the diagnosis, but we know what that is just by talking to the patient, to be honest, and then we can move on and tell them what to do to help them get better.
Oh, this was fantastic, honestly. Like, I feel like we can talk and talk and talk and talk, and we've actually
it's such a big topic.
7 extra minutes. We've taken 7 extra minutes of your time. Like, I think it's like, I hope like it gives people, like, you know, solace, or gives them a bit of peace and understanding of how devastating these conditions are, right? You know, sudden deaths. You just wake up, a person's here one day, there's no notice, and you don't understand. There are 1 million questions to ask that no one can really answer. But I think you've talked about it so brilliantly, honestly. Like, it's been amazing talking to you, answering questions. I'm sure everyone that's logged in has been happy for the questions and how you've answered it. And I think what's most important is that you've said it to patients and people the way they can understand it. And I think I couldn't thank you more for tonight.
It's an absolute pleasure. You know, it's really important. And I think, you know, as I say, you know, if there has been something, just speak to a cardiologist. These conditions, there's so many of them, and there are very specific treatments. And, you know, a couple of the electrical conditions, there are websites, there are drugs you've got to avoid and all that sort of thing as well. But it's very specific to the condition and the individual. But, you know, my advice to people is that we are here.
Exactly.
Right?
That's why we're here.
No one is wasting our time. So if you have anything, just come and see us. You know, we're more than happy to help, you know, do whatever's needed, the test that's needed, and reassure if that's all we need to do. And at least it gives peace of mind. And if there is something, then we deal with it.
I'm going to share something with you before you go. Someone said, thank you so much, as I have had concerns for a while, which were addressed tonight. We'll sleep very well tonight. That is beautiful. And I think that's how everyone feels. I think people are going to go to bed tonight smiling, sleeping, knowing that, you know, there's someone there that will always help you. And I think what's also really great is that Dr. Aisha works at the One Welbeck, and I must say a really big thank you to One Welbeck for lending you, or how do I say, giving you to us tonight.
Well, thank you for
One Welbeck
asking.
is like one of the largest specialist facilities for diagnostics and therapies and surgery in the UK, and it's like a beautiful, beautiful hospital. I remember walking into the cardiology. That was the first part I came to, actually, was One Welbeck Heart Health, yeah, and it was like, where am I? It's just like a hospital, right? It is not
It is
just
nice.
beautiful, it's full of like skills, you know, from top to bottom. It's just an extremely skilled hospital. And it's been great being partners with you guys for like it's almost 2 years now that we've worked with you guys. And it's been amazing. Like, you know, the amount of care patients get from the front door, like from the team, everyone, like they're just great. Rupal, there's Tash, like the whole team is just super amazing. And then obviously the doctors are the best in the country. And I think it's great to have you guys and like be able to navigate patients for us. And I just want to say a really big thank you to One Welbeck, and a big thank you to you. And then also I want to thank everyone that's logged in today. I know today, unfortunately, we're going to apologize to the American guests because we've completely forgot today was Thanksgiving, because we plan our dates 6 months in advance, you know, and because of that, a lot of people couldn't join. But obviously you guys can always catch up on YouTube and see what we about the discussions today. And if you still have more questions, hopefully we'll beg her to come back again. I'm just being a little bit cheeky, but hopefully.
It's all right. You don't have to beg. I'll come. It's an honor. Honestly, it's an honor and privilege, you know, to be asked. And you know, I've got to say, you know, it is true. I know I might be quite biased, but when One Welbeck is really not, and honestly, patients do feed back to me, but they say, which I always think is the hallmark of good healthcare, is that, and as you've said, Chi-Chi, is that actually people say every person they meet, be it the person they've sat at reception, big smile when someone's feeling anxious, really helpful, our booking staff, the people doing the investigations, all helpful, kind, friendly, considerate, empath. You know, I've only heard, thankfully, good things for all of my colleagues and the autism.
Actually, it's just the hospital after my heart, because how we work is that we actually visit the facilities, we look at what the doctors do, and then we recommend them, right? So I'm always like, honestly, it's a beautiful place. And I think doing this collaboration with the talks is like fantastic, because people are able to ask the questions that bother them, because most people meet doctors that don't actually explain things to them. And that's what you don't see at the One Welbeck. The doctors come to your level, they speak to you with the same language that you want to hear. And I think that's great. And I want to thank you guys again. And I want to thank my team. Like tonight was supposed to be a little bit chaotic because we had a bit of technical issues in the beginning, but everyone stepped in well. So the whole Anomo Health team they've all logged in from Nigeria, from the US, Amazing. And then from the Middle East. Everyone's like here today just to support and make it work. It's not just about me, it's about the whole team. And I think I want to thank each and every one of you, and back-end support, Ahmed. Like, thanks everyone for actually joining, and obviously for everyone else that's actually taking out their time. I know, like midweek, 7 p.m, you guys come in every week. You still come to listen to what we have to say every 2 weeks or every week sometimes. Thank you so much for joining. And I think from all of us, Dr. Aisha, we thank you so much for tonight.
No, it's right. It's a real pleasure. I've got to say, Gigi, thank you for this, because obviously when I got asked, I said, oh, you know, do I have to do a presentation, which is fine. But actually, I think the way that you run this is really good, because
thank you.
As you say, people get to ask those questions that are clearly bothering them, which can very simply be answered. And the questions have been fantastic. You know, those are the day-to-day things that, you know, these phrases get thrown and there's no really understanding of what it means or what they need to do. So I think this is great, actually. So thank you for having me. I've really enjoyed it.
Thank you. And I think our hearts, everybody that's joined today, and we want to say, like, offer all our love and support to obviously the Steve Spotlight Osagie family, who Steve was part of this initiative when you know, he joined us after we started. And it's sad he can't be here with us today, but we hope that for people joining from his family, from his friends, that somehow tonight does help you not understand. I think that's not the right word to use, but gives you a bit of like peace and a bit of like some unanswered questions that we've had. And I hope it touches someone's life also, that by doing this for Steve and doing this for the team and doing this for every patient it's involved with us, that somehow we can save more lives. And I think that's what we are as doctors, right? We work together as a team. It's not just about one person, like Dr. Aisha said. It's all about everyone working together and collaborating to make sure that we touch more lives. And today we've been a bit cheeky and gone 15 minutes over time, and I must apologize, but I think that's our Thanksgiving present to the Americans, right? So I'm going to say good night from London. I think it's still afternoon in America, and happy Thanksgiving. And for people in Nigeria, it's also good night. The people in the Middle East it's past midnight in Dubai already. And I say goodbye to them also. And I say happy Thanksgiving. And I hope, like, by giving thanks, spending time with us today and collaborating, we won well back with Dr. Aisha, we've been able to actually do something of Thanksgiving, I think. And even though we're sad about Steve, we still thank God for his life. That's the honest truth. I think that's the word to use, is Thanksgiving still, because he's touched us that we could remember him. I remember that he stood for us at a point when we needed him most. Like, we met him when we're in crisis. And I'm happy that we've been able to do this for him tonight. Thank you so much, everyone. Thank you so much, Dr. Aisha.
Thank you.
Good night, everyone.
Thank you, everyone, for coming. Thank you.
Okay, good night, everyone.
Night.
See you in 2 weeks, I think. 2 weeks time. Bye, everyone.
Well done. Good job. Good night.
Good
night. Thank you.
Thank you.
Good night.
Thank you.
Bye.
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 Bye. Bye.